Welcome to this recorded site initiation visit for the TACTIC-R study, a multi-arm therapeutic study in pre-ICU patients admitted with COVID-19 using repurposed drugs. TACTIC-R is currently studying the investigational medicinal products baricitinib and ravulizumab. The study is led by the Chief Investigator, Dr. Francis Hall, from Cambridge University Hospital's NHS Foundation Trust. COVID-19 related disease is attributable to infection with the SARS-CoV-2 virus. The illness can be divided into several clear stages. Stage 1 disease, which is an acute viral illness characterized by cough, fever, muscle pain, loss of taste and smell, and sometimes gastrointestinal symptoms. The vast majority of people who experience this stage of disease will recover within a matter of a week without sequelae. However, a minority of patients will go on to develop a second phase of the disease where they start to become more breathless, fevers persist, and then it evolves into a third stage of disease with a severe immunological response, respiratory failure requiring intensive care support, and ultimately potential for myocardial or renal injury. It is this third stage of disease that carries a high mortality, and current strategies to intervene for this disease are targeting preventing this stage. The TACTIC-R study is specifically looking to recruit patients who are either late in stage 1 or early in stage 2 to intervene and modify the disease course, preventing progression to respiratory failure. There are some important points to consider. Perhaps most important is that we know that a majority of patients with stage 1 disease will not progress through to stage 2 or stage 3. And, as part of TACTIC-R, we are evaluating immune modulatory therapies that are not without risk, and therefore to ensure equipoise in our research, it is important we recruit patients who have a significant chance of developing stage 3 disease in order to justify enrolment in a clinical trial. TACTIC-R does this using a risk progression score, which I will come back to. The study identifies adults with confirmed or suspected COVID-19 disease. That's important. Many clinical trials at the current time are limited to patients who have a positive SARS-CoV-2 RT-PCR test, and this is not the case for TACTIC-R. Patients are identified and after baseline assessment are randomized to one of the interventional arms, either standard of care, and at present, ravulizumab, which is an intravenous infusion on a weight-based dosing regime, baricitinib, which is an oral tablet dosed at 4 mg daily, or 2 mg for some patients who are older or have renal impairment, and it is possible that in the future additional arms may be approved, pending regulatory and ethical permissions. The primary endpoint is organ failure. Secondary endpoints include many outcomes, including the WHO ordinal scale. Data collection continues daily while patients are in hospital. Follow-up occurs at day 28 and day 90. The first drug to be included is baricitinib. This is a drug that has established a license for rheumatoid arthritis. It is an inhibitor of the Janus kinase pathway, specifically the JAK1 and JAK2 kinase pathways. The effect of inhibiting these pathways will be to reduce the signaling potential of cytokines such as interleukin-6, interleukin-10, interferon gamma, and also the granulocyte and granulocyte macrophage colony stimulating factors. Baricitinib is also of interest as a treatment for COVID-19 as the drug may reduce receptor-mediated endocytosis of the virus itself, potentially having direct antiviral effect. Baricitinib is dosed at 4 mg, which is 2 2-mg tablets, daily for 14 days, which continues from the first dose until either the patient meets the primary endpoint or the patient is discharged from hospital. Dosing does not continue once the patient has met their primary endpoint or been discharged. The dose of baricitinib should be reduced for people over the age of 75 years or people with renal impairment where their estimated creatinine clearance is between 30 and 60 mL per minute. A creatinine clearance below 30 mL per minute would be an exclusion for this drug. The toxicity profile from baricitinib is established from many phase 3 clinical trials in rheumatoid arthritis, and for the whole, the drug has a favourable safety profile, hence its inclusion in this study. In addition, the toxicity of baricitinib has primarily been associated with long-term use. Indeed, in the trials in rheumatoid arthritis, no laboratory monitoring takes place within the first 2 weeks of therapy, and we are only dosing people for a total of 2 weeks in TACTIC-R. However, toxicities that have been reported include hematological effects such as suppression of hemoglobin and platelet counts, transaminitis, and there is some recent literature with concern around the risk of thrombosis. The risk of thrombosis with baricitinib is small, and it is associated with long-term therapy. Paradoxically, we know from other JAK inhibitor therapies, such as ruloxitinib, which is licensed for treating hematological diseases, such as polycythemia rubra vera, that actually in that setting, a setting within which background thromboembolic events are much higher, the effect of the JAK2 inhibition with ruloxitinib is to reduce thrombotic risk. It is therefore, in the context of TACTIC-R, we believe there is equipoise that this drug offers sufficient potential benefit to justify any of the potential risks. Ravulizumab is a drug that is licensed for a condition called paroxysmal nocturnal hemoglobinuria. This is an inherited disorder in which the complement cascade causes damage to red blood cells and chronic anemia. Ravulizumab has revolutionized treatment for this disease, alongside other complement inhibitors. The specific mode of action of this complement inhibitor is to bind the C5 component, part of the final common pathway of the complement cascade. This will switch off amplification of inflammation. It decreases the ability for complement to damage cells. The rationale for using a complement pathway blocking drug in COVID-19 is particularly based upon the fact we know other similar diseases where there is an infectious trigger for an inflammatory process, such as the hemolytic uremic syndrome, we have seen efficacy of complement inhibition. We know that in SARS-CoV-2 post-mortem samples, patients have histological evidence of complement activation, with the membrane attack complex visible on histology. We also know that in the clinical setting of SARS-CoV-2, biomarker analysis confirm activation of the complement pathway. In addition, and this is true for both baricitinib and ravulizumab, there has been compassionate use data also for both of these agents, which look promising and support the decision to include these drugs in a randomized controlled trial. The dosing of ravulizumab is weight-based. It is a single infusion, and the drug has a long-lasting effect on the complement pathway. So once a patient has been dosed, there is no need for any repeat dosing. Toxicities, well, there are very few. There are risks of infusion reactions, as with all drugs. The risks with ravulizumab are no higher than the risks with other monoclonal antibodies. One particular concern about anyone who is on complement inhibition is the susceptibility to particularly meningococcal meningitis. So whilst the overall infection rates with ravulizumab are very low, and complement inhibition is not traditionally associated with a susceptibility to other infections, there is a specific risk of being unable to form a host response against meningitis. Therefore, all people who get dosed with this arm of the study should receive prophylaxis against meningococcal meningitis with antibiotics for 8 months, or if the patient can be vaccinated against meningitis, and I'll come back to the process regarding this later, then they only need to continue the antibiotics until 2 weeks after they have received the vaccine. Ravulizumab also requires contraception for women of childbearing age for 8 months after dosing. The inclusion criteria for the TACTIC-R study include adults who have a clinical picture strongly suggestive of COVID-19 related disease with or without a COVID-19 RT-PCR test positive. This is an important point. Whilst many studies are limiting recruitment to patients who have a RT-PCR positive result, we recognise that up to 20% of people admitted acutely unwell with COVID-19 have a negative RT-PCR on the first testing. We also realised that Tactic R is looking to intervene in patients earlier in the disease course, and recognising that some people deteriorate rapidly during their inpatient stay, it is important that people are given access to the Tactic trial without having to wait for a second positive test, which could delay things by 24 or 48 hours. In addition to having a clinical picture suggestive of COVID-19, we also need to be sure that patients have significant risk of progression to stage 3 disease to justify risks associated with immune modulation. To this end, we use a risk count, and risk counts must be greater than 3 or exactly 3 if the risk count includes the point from the radiographic severity score. I will come on to those separately. In addition, the patient must be considered an appropriate subject for the intervention with immune modulation in the opinion of the investigator. If there is uncertainty about that, that can be raised centrally with the chief investigator if there are questions. And in addition, we point out that all patients should be maintained on venous thromboembolism prophylaxis or current maintenance therapy during inpatient dosing according to local guidelines. This is not part of the clinical trial procedures, but this is just highlighting that, as we are aware, venous thromboembolism appears to be increased in patients with COVID-19, and all patients should have a VTE risk assessment performed on them, both during the admission and on discharge. The risk stratification algorithm is as follows. There are 8 items. Each of these items scores 1 point. The derivation of this risk score was based on the first 200 patients admitted to King's College Hospital. We further validated this score on the subsequent 1,200 patients. The risk score identifies people at increased chance of progressing to stage 3 disease. The score includes radiographic severity. I will explain the scoring system for this in the coming slides, and there are separate videos talking about this. Male gender, non-white ethnicity, the comorbidities, diabetes and hypertension, a neutrophil count greater than 8, an age over 40, and a CRP over 40. Each of these scores 1 point. In order to identify patients for inclusion in the study, patients must have a total score of either 4 points or greater, or 3 points if one of those points is derived from a radiographic severity score. Some people will ask about not including measures such as a lymphocyte count or a neutrophil lymphocyte ratio, or what about a D-dimer or LDH? And of course, there are many papers now that have been published looking at different predictive markers for COVID-19 progression. The rationale was as follows. Firstly, some of those markers are not routinely done on all patients admitted to hospital, for example a D-dimer. There have been concerns raised that doing a D-dimer results in an immediate decision to do a CTPA. Given we know the risk of renal disease and our concerns about administering IV contrast to people who are dehydrated, such as in COVID-19, there's concern that recommending a D-dimer in all patients could increase the unnecessary use of ionising radiation and exposure to contrast. Lymphocyte counts were looked at in the model, but unfortunately, lymphocyte counts do not follow a linear relationship, and both low and high lymphocyte counts are predictive of a poor outcome. And neutrophil counts behaved in a more stable manner. It was therefore for pragmatic reasons that we chose to select these 8 items that have a clear relationship between the risk of progression to stage 3 out of all the possible variables that we explored. It is worth mentioning that of these items, the single item that carries the most importance is the radiographic severity score, and that is why, if that item is included, we would accept people who have a lower overall score, i.e. a total score of only 3, if the radiographic severity score meets the criteria. Scoring the radiographs requires you to look at the X-rays, looking at each lung separately. We would highlight that This scoring system is not intended to be done by a radiologist, but should be done by the trial clinician who is assessing the patient. The scoring system is also not a diagnostic criteria for COVID-19, but in people in whom you have confirmed that you suspect COVID-19 is the most likely diagnosis, it is a way of predicting the risk that they will progress towards stage 3 disease. Very simply, each lung is scored between 0 and 4. 0 reflecting a lung that has no abnormalities, and 4 a lung that has over 75% of the lung field affected by infiltrate. Scores between 1, 2 and 3 reflect proportions of the lung within within those strata. There is a separate video giving other examples of lung scoring, and also a recording from a respiratory physician, Dr. Mike Waller, giving some advice on the approach to interpreting lung radiographs in COVID-19. The key exclusion criteria from the study are listed here. If you're unable to take consent from a patient, we do accept representative consent from either a next of kin or an independent healthcare provider. Patients must not be mechanically ventilated at the time of dosing. That means, for example, if you were to consent a patient but they were to be intubated between consent and dosing, they should then be removed from the study and not dosed. Patients with contraindications to study drugs, including hypersensitivity to any active substances or excipients, are excluded. People on any study investigational medicinal products should be excluded. There are sometimes questions, for example, what if a patient was on a community prevention study, including hydroxychloroquine, but is then admitted to hospital with severe disease? Would they be eligible for inclusion? So in that setting, the answer, if they have stopped the medicinal product that they were currently using, the answer may be different. And if you have questions about this, you should contact the chief investigator and the central study team. Anyone who has unresolved and serious meningitis infection should not be included. Anyone unwilling to be vaccinated against meningitis or receive the prophylactic antibiotic should also not be included. We don't ask for any prior screening to tuberculosis or hepatitis, but people who have known active tuberculosis or hepatitis should be considered excluded from the study. Someone, on the other hand, who has controlled hepatitis B or C on treatment would not be excluded. Concurrent participation in another interventional clinical trial should not be is an exclusion, but observational studies are fine. So someone is absolutely fine to be enrolled in one of the many observational studies in parallel to tactic. Moribund patients at presentation or screening should not be included. Pregnancy or unwilling to adhere to the pregnancy advice in the protocol is an exclusion. There are important exclusions from the laboratory parameters, including either transaminitis more than 5 times the upper limit of normal, or stage 4 chronic kidney disease or people on dialysis. To assess CKD, you should use the Cockcroft and Gault estimated creatinine clearance. Patients receiving probenecid, which is a drug that interacts with baricitinib, should be excluded, and also people on long-term IVIG treatment are excluded. And finally, as always, any medical history or clinically relevant abnormality that deemed by the principal investigator or the monitor to make a patient ineligible is also an exclusion. The primary endpoints for the tactic study are the time to the instance of any one of the following items: death, mechanical ventilation, that is intubation, not CPAP, extracorporeal membrane oxygenation, cardiovascular organ support such as a balloon pump or pressors, or renal failure requiring either hemodialysis or hemofiltration, or peritoneal dialysis, as some of us have been using in recent times. Secondary endpoints are many. These include the WHO ordinal scale. They include proportion of people with adverse events or events of special interest, and that's a particularly important aspect of immune modulation studies, is the ability to capture adverse events. Time to recovery of normal oxygenation levels, time to negative SARS-CoV-2 PCR results, duration of hospitalization, and time to clinical improvement. The sample sizes for each arm are calculated using a interim analysis. So, with the tactic R, this uses what is called a Bayesian adaptive design. Patients are randomised with a plan to recruit 125 patients per arm. We know, however, that as we go through the study, we will look at the data, and the statisticians and the Data Safety Committee will review information, and that means that potentially an arm may be withdrawn or an arm may be added during the course of the study. The initial period will include 125 patients per arm. If at that point there is clear evidence that a drug is a winner, it is effective for this disease, then the study may have reached its primary endpoint. However, if there is no clear winner, the study may continue. There will then be a second analysis at the point at which 229 patients per arm have been reached. The main schedule of events is shown in the study protocol. I'm not going to go through the individual points, but I will highlight just a couple of aspects. During the follow-up visits, it is apparent that we ask for vital signs, medication reviews, but we do not ask for repeated physical examinations. It is important that as we go through the study assessments, that you minimise the amount of PPE used and the amount of study participants, the study personnel, who have to be exposed to this virus. Therefore, we have minimised the direct contact. Research blood sampling is required, and when this is done, this may be done by one of the research nurses or other study team. And obviously, in centres that are doing the research blood sampling, this will require direct patient contact. But other aspects, such as review of adverse events, we anticipate will be done from the medical record. Ravulizumab. As this drug inhibits complement cascade, there is a risk specifically of susceptibility to Neisseria meningitidis, and for this reason, patients should be offered prophylaxis with antibiotics such as penicillin V, the preferred option, or in people who are penicillin allergic, a macrolide such as erythromycin. The antibiotics should be continued on discharge. Now, during the admission stay, many patients will be on broad-spectrum antibiotics, which will mean you do not need to add necessarily penicillin V if they're already on high-dose IV antibiotics that would cover Neisseria meningitidis. Your local investigator can determine this. But on discharge, the antibiotics need to continue, either for 8 months or, for most people, 2 weeks after they have received meningitis vaccination. Coordination of this should be done locally, so the local PI should confirm that antibiotics are given or that the vaccination is being given. So there may be some people, particularly younger patients, who have received full vaccination before they even enter the study, although we suspect those numbers will be few given the average age of patients presenting with COVID. I'm going to focus on this in just a little bit more detail because the vaccination aspect of this is important. Patients who are discharged, they need, and this is an example of the case report form that you will need to complete, they need to be offered the meningitis ACWY and the meningitis B vaccines. These should not be given in hospital. We don't believe while someone is acutely unwell that their immune system will cope well with this. So we believe that it would be more sensible to wait at least 4 weeks after discharge before vaccinating. Once they have received those vaccines, 2 weeks later they can then stop their antibiotic prophylaxis. So the 8 months of antibiotic prophylaxis is only for the minority of patients who cannot complete the vaccination course. We will ask you to report to us about the meningitis vaccines, both on the day 28 and the day 90 follow-up forms. Consent can be taken primarily from the patient, and that's what we would expect from most people. However, it is also possible to take consent from a legal representative. That must be someone who can give consent on behalf of the adult when the adult themselves lacks capacity. There is a legal representative information sheet, and there's a signature space for them on the main patient information sheet and consent form. If a patient who was previously incapacitated regains capacity, consent should then be sought. This is most relevant in the context of delirium, which we know is increased in people presenting with COVID-19. It is worth mentioning that there is a separate video talking about some of the challenges of consent, which may be helpful to watch. When taking consent using a personal legal representative, it is important that that person is not connected with the conduct of the trial in any way, and is suitable to act as a legal representative by their virtue of the relationship they have with the patient. This is usually going to be someone who is a next of kin. That is the preferable first option. When that is not available, a professional legal representative can also be used. This should be someone when the next of kin is not available or doesn't exist, and might be a doctor responsible for the medical treatment of that patient. However, that doctor must be independent of the study. Basically, it means they should not be on the study delegation log. Once people enrolled in a study, they will be assigned a trial ID number. That ID number will increase sequentially by site with a unique code denoting which hospital they are being recruited to. For example, the trial ID for my hospital at King's is N02. Once people have completed their baseline visit, the investigator will then log on to the sealed envelope website. The web address is shown on the screen here. They will then, once they have entered the patient information, be given a randomization allocation to decide which arm the patient is randomized to. If you haven't logged in before, the sealed envelope website is relatively intuitive to use. Once you first log in, you'll be asked to change your password. You then select your role once you are in the system as an investigator at the appropriate site, and you identify the randomization icon. You'll be asked for information on the subject ID, which you've already received from the trial enrolment, a date of birth, initials, date of informed consent, and confirmation that inclusion and exclusion criteria have been met, written informed consent has been obtained. And then you'll be asked to re-enter your password to confirm, and the patient will be assigned to one of the arms. It is open label, so you'll know immediately which arm the patient has been assigned to. Confirmation will be sent to the Tacticar lead trial office, the randomizer, pharmacy at site, and also investigators at the randomizing site if they're delegated to the sealed envelope website. Email notification should be printed and stored in the ISF. If you want more information on randomization, this is in the trial procedures manual. At present, we're collecting follow-up data on paper case report forms. Just a note on this, you will be taking patients in and out of side rooms or in and out of wards that are being cohorted for COVID-19. It is important that from an infection control point of view, you minimise the risk of transmitting the virus, and we know that the virus can survive for short periods on surfaces such as paper. Therefore, you may have local processors in your hospital for avoiding moving paper in and out of patient rooms. For example, using secure sharing applications such as Pando, one of the NHS apps, to be able to photograph and then print off outside the room copies of consent forms. In addition, case report forms can mostly be entered and completed away from the patient bedside in separate rooms, so the paperwork does not come into contact with the SARS-CoV-2 virus. Paper CRFs are available for screening baseline days 1, 2, 3 to 14, the follow-up days at 28 and day 90, and there are also ConMed forms. These should be returned electronically to tacticar@adambrooks.nhs.uk. Patient identifiable information should be removed from all CRFs before sending. This is an example of the baseline treatment form, and I will let you look over these in more detail in your own time. Tacticar also collects research samples. Bloods are collected as follows. We're looking for RNA PAX gene tubes, EDTA for DNA sampling, EDTA for plasma sampling, serum samples, and citrate tubes for PBMC processing. We're looking for a maximum of 30 mils to be collected at each time point. Tubes should be labelled with the Tacticar trial ID number and collection date. And we are looking to collect information for biomarker analysis on days 2, 6 and 14, or if someone is discharged, we ask you to collect a sample on the day of discharge, even if that is sooner than day 14. Where feasible, we would also like sampling at day 28 and day 90, but we're aware this should only happen if the patient has a face-to-face visit. In your centre, there may be many other studies that are taking part. We know that, for example, there are other research studies linked to bioresource centres that are collecting sampling. Now, we need to acknowledge that there are finite amounts of blood you can take from any patient. However, it may be appropriate that if bioresource samples are needed, and these should be taken prior to the first IMP dose, these may be taken in parallel to the tactic trial. However, separate consent is needed, so under bioresource ethics, you cannot consent to the people just to tactic-R and then also collect for bioresource. You need to undertake both consents in parallel. We know from experience at our hospital that where there are multiple competing studies, and this includes not just for other biomarker studies but also other observational studies, it is often easier to approach the patient at a single time point with just one person who talks through the breadth of studies available, and so that patients are not approached on multiple occasions for multiple different studies in a short time frame, particularly acknowledging that being admitted with COVID-19 is a very frightening time. Therefore, it is important that within a local hospital, the different studies that are active should be coordinated with each other. Evaluation of safety data is important. We ask for you to report on adverse events throughout the study, and these should be accompanied by seriousness assessments, causality assessments, expected assessments, and severity assessments. The details of the adverse events, how they're recorded, specifically around the serious adverse event reporting, which should be sent to the coordination team within 24 hours of site awareness. Causality should be reviewed, and if we suspect that there's a serious adverse reaction, that is, a serious adverse event we think may be related to one of the investigational products, then this requires immediate escalation and close follow-up. It is important to acknowledge that known manifestations of COVID-19 are not being reported. If they are serious, they're recorded in the trial CRF. SUSARs are suspected, unexpected, serious adverse reactions. By that, these are defined as adverse reactions that are both serious in nature and for which there is a reasonable causal relationship suspected, although not necessarily confirmed, with one of the medicines in use in the study. SUSARs must be reported both directly to the MHRA via the eSUSAR website, the address shown here, but also to the REC sponsor, Alexion Pharmaceuticals, and the PIs. And in the event of a SUSAR, there is a substantial amount of additional information that we'll require, and please contact us immediately if you need any other information. Tactic-R pregnancy reporting requirements are specific to people who've been in the ravulizumab arm. Anyone who's participating in the study who reports pregnancy up to 8 months after after treatment completion with ravulizumab should be notified via the trial coordinator within 24 hours. And this means notification to the chief investigator, the sponsor, and also Alexion, who are the manufacturers of ravulizumab. IMP manufacture. The drugs are provided baricitinib by Lilly and ravulizumab by Alexion. They are packed, labelled, certified and then stored and distributed to sites by Rena Clinical. Baricitinib is straightforward. It is a tablet with no special storage conditions and will be supplied to units in packs of 14 2-milligram tablets. Ravulizumab does have a cold storage chain. It must be maintained at temperatures between 2 and 8 degrees, and it is delivered to sites in vials of 30 ml containing 300 milligrams of drug. The distribution will be initially triggered by site initiation. Supplies for 5 patients will be sent initially, which will include 10 packs of baricitinib and 50 vials of ravulizumab. Ongoing shipments will then require manual ordering by the site. As you consent more patients, you can trigger a further delivery. It is important that you need to balance the maintaining ability to recruit and managing a finite stock supply. As we open up more sites, we will need to be mindful about the amount of drug available and the speed at which we can get drug to sites. So we'll be asking sites not to stockpile large quantities of drug. The IMP, once it's received at sites, will be sent to pharmacy, and on arrival, using TempTail, if it's for ravulizumab, assess whether transit conditions were satisfactory and if there are any temperature deviations. Receipt documentation is then returned to the Rena Clinical, and if there wasn't satisfactory temperature control, that drug that has been supplied needs to be quarantined, and we will contact Alexion to confirm if it is fit for use. When new batches are delivered, again, those batches should be quarantined so that the existing stock should be used up first, i.e. the most recent supply should be used first. Here's an example of the site IMP order form. Once an IMP is on site, and again this is specific to ravulizumab, again it must be temperature controlled. If a temperature goes below 2 or above 8 degrees Celsius, sites must then quarantine the stock as per their local procedure, and again they must inform both the TC and Alexion to provide details of the excursion. Alexion will then confirm whether or not the drug remains fit for use. And again, here is the trial temperature excursion form. I'm not going to go through the detail of preparation of ravulizumab for infusion. This will have been covered in the live site initiation visit, and there are detailed information on how to prepare ravulizumab in the study manual. At this point, I will say thank you for listening. Good luck recruiting to the TACTIC trial.